plug in. It's into a clear acrylic header, which has electrical connections and a screw to make that connection secure. And then on the patient end, down in the heart, you're going to have the two electrodes, cathode and anode, cathode's at the tip, and you're going to have something to secure it into the heart. So either a screw or anchor-like tines. And we use a programmer to both view the live activity, change permanent programming, and perform intraoperative manipulation of the pacemaker and system. So that's the very broad. So the parts of that pacemaker I kind of alluded to. You've got the can, right? The hard metal part is made of titanium. The header is the acrylic part where we can see through. That's obviously important because you want to be able to make sure that the connection is good and be able to visualize any problems. And then inside there's a computer network system that has all sorts of, very tiny parts on it, including a motion sensor, a capacitor to be able to increase the voltage from the battery voltage. We have to deliver higher voltages to the patient. So normal pacing outputs range from about 1 volt, it's in the volt range, from about 1 volt to about, I think the maximum on most devices is 7.5 volts. The batteries only go to 3. So how do you get 7.5? You have to store it, and you use a capacitor to do that. So you charge the capacitor twice, basically, or you link it up in, it'd be series, in order to get the voltage multiplier.
And that's for someone that just will need like a 6-volt charge every day.
Every beat. Some people require higher outputs. So when we put these in, we look for 3 main measurements, and we'll get to that in a second, of a pacemaker, of a pacing system or of a lead, are how much voltage does it take to stimulate? How much voltage do we measure for every intrinsic beat? We want that as high as possible. We want the required voltage, although known as the threshold, to be as low as possible, right? Because we run efficiently then. We want to hear really well and not use too much energy. And then the last part is the system resistance, which tells us basically if there's been any changes long term to that circuit. You get a broken circuit, resistance goes up, right? You get a short circuit, resistance goes down, right? You guys have taken some electrical networks classes for, they include that in like physics for pre-med, right? Kind of?
Well, pre-med and pre-med. So some have.
I took physics in undergrad.
Okay.
I took physics.
All right. So the pacemaker itself, also known as the can or the device, it will be used interchangeably in industry and the lab. Has obviously changed over the years. We started out with something very basic and hockey puck-like that lasted a few months long. That was the guy that we just discussed. On to much more modern stuff. And this presentation is a few years old even because it takes a while to get through legal. So the one on the right hasn't been implanted for almost 10 years. We have gone 1, 2, 3, 4 generations beyond the one on the right already. So, all of these, the 2 on the right are bipolar pacemakers, I believe the ones. I see a bipole in the center, and then the older one would have been, or rather 2 leads. They're 2 lead pacemakers. Atrium and ventricle. So, a little bit bigger diagram here. This is one of our older models. You'll still see these in clinic sometimes. I checked them this morning. You've got a can on the bottom and a header. So when the physician actually plugs into the device, we're going to get the leads positioned. We'll get them in their appropriate places and assure that the connections have been made effectively into the right muscle. We've got good, healthy connections and that they're secure and not going anywhere. And then we plug into this and screw down at the set screws. You can see the tiny holes there. And all of this is sealed so that blood and, saline and other things don't get in. Inside there's also a radio marker, so if for some reason you ever need to figure out what kind of device the patient has, when you fluoro this or take an x-ray, the x-ray does actually pass through the can. It will be, and you'll see the circuit board inside, and it's marked with different identifiers for different brands. So he screws it down like so. You get a nice secure connection, and then I check it using the computer. We're not going to get into all the other stuff inside. They also used to make nuclear pacemakers, but that's a long time ago. They decided that that was a bad idea. Okay, so next. Let's say we're going to do, I'll skim through these real quick. They're not very long. Okay, so what's a pacemaker lead? The lead has insulation, 2 layers of insulation. So you've got inner coils of wire. For each wire that you want to pass through, it's not just a straight shot like a fishing line. It actually coils around a center lumen. And so you've got middle lumen insulation. Wire number 1, we call them filers. It's like a big helix. Then insulation, then wire number 2, and then outer insulation. So all of those layers make up the lead. The inner filer is actually connected in such a way that on an active fixed lead, it turns and you can screw out the helix. So I'll show you how that works. This is a passive lead. So you can see at the end there, it has a silicone passive fixation helix, or excuse me, anchor. So those splines expand out. When they go through the catheter to introduce this into the heart, they compress down. And then when they get out, they just kind of, point out to the sides. And they engage with the trabeculation in the chamber of interest. You can think about where would you be able to deploy this in the heart based on your kind of understanding of anatomy. Where has trabeculation? The ventricular where?
Like actually the atria.
You could do there too, where? So in both cases, it's the end of the line. You have to go into basically the apex of the RV or the appendage of the A. Hardly anywhere else has enough
like
encircling smallness with trabeculation to make this hold, right? You're not going to be able to put this in the septum. Won't work. So pacing travels from a positive anode to a negative cathode. We do cathodal pacing. It's a little bit complex to understand the way that current flows, but I'll just keep it to some systems are bipolar pacing, which means you can take the can out of the body and then the positive and negative are inside the lead. That's all you need in order to make the heart beat. Unipolar pacing, which is older stuff, older technology, means there's only one wire that's active inside the heart. One tip, one electrode, and you got to complete the circuit. So the can becomes the other part of the circuit. It becomes the anode.
I remember that.
For a unipolar lead. So if for some reason, and this is only pertinent for people that are going to do pacemakers for your scope of practice, but if you disconnect a unipolar device and the patient is dependent, if you take it out of the body, it stops pacing. Put it back, right? It doesn't work. I've been there. It's not that fun. All right, so here we go. That's kind of my.
Do they make unipolar still, or is it kind of gone?
I'm sure somebody does, but for implants in the United States, I don't know of any unipolar systems going in. There are unipolar epicardial leads, I believe, but in general, all the stuff that's implanted today is bipolar. It's just preferred. Okay, so that's another passive lead. Let's see if there's one of the. I can't cover every topic in pacing in an hour, so here we go. That's an active fixed lead. We use lots more of these than the passive. You'll see it has a little helical screw that's extendable, so it drops back in. And when you screw on the terminal pin, there's a little tool. This is attached to it, and so it screws out. And then when you screw it back, it comes back in. You'll be able to see it on X-ray. This basically screws directly into the muscle. It's a much more secure connection. So these are, we don't worry about them moving around as much. We don't worry about pulling it back as much, and it provides you a lot more flexibility because you can put it in places that aren't naturally designed to hold a lead. You can screw into any wall, basically. All right. The trade-off being that you're pushing a sharp tip toward a wall that might have pericardium on the other side of it, so you have to be careful where you put it. Okay, so how are we going to do it? Implant technique. All right, for the implant, from a doctor or a lab perspective, they need some components. So you're going to need introducing accessories and all the tools to be able to perform the surgery. Implants are almost always done in either an EP lab, a cath lab, less common, or an OR. And preference is to the places with the best flora. It's not required, some people just do it, but Tarzana, for example, is a dedicated cath lab, or excuse me, a dedicated EP lab, where they also do cath. And the thing that's going to distinguish an EP lab from a cath lab is more equipment to be able to do epicardial ablation, or excuse me, to be able to do electrophysiologic ablation. So they're going to have more sophisticated recording systems. They're going to have systems to be able to put catheters inside the heart with electrodes on them and record the signals. And they're going to have at least one, if not both, major brand mapping systems. So that's Biosense Webster's Cardo, which is the competition, and St. Jude's Ensight, which is us. There's a, I mean, yeah. And so the way theirs works today is they use magnets and impedance patches, and we use impedance patches and magnets. So, you know, that's how that goes. But the lab for EP is almost always going to have high quality flora. So big II, you want to get really clear signals because catheters are small, and you want to get very fine location of them. This is not ortho. You need really nice pictures. So, let's see. What do you need? We use a programmer. This is different on every brand. So they're all proprietary, and they're required in order to interface with a different branded device. St. Jude's is white, Medtronic's is blue, Boston's is greenish, kind of. Biotronics is white, and Soren's is not very good. So the most of them have touch screens. Everything's basically included in the box, and they include the ability to connect a patient EKG directly to it, which is really good if you ever get asked to check one. Always look at the EKG because, you know, it's a good way to make sure that you're still pacing. And then we have a module that's included that allows us to collect directly to the patient with cables. So before we ever use the pacemaker itself, we're going to have the wires in. I want to be able to pace through the wires without opening the expensive pacemaker. I want to know that everything's working and then pull the right one. Because if, say, we're going to do a BiV and we can't get the LV lead in, it's now become a dual chamber device. We don't have the device open yet. So we use what's called a pacing system analyzer. And it's kind of like it's like a glorified temporary pacemaker. I'll pull it up here for you. What it allows us to do is to apply, you know, paced rhythm. So at different rates, so 60 beats and 90 beats, 100 beats a minute, at different outputs, so you can go anywhere from, you know, 0.2 volts all the way to 10 volts, and we can also listen for sensed rhythm. We can measure what it looks like. All right, so this is the general, this is very general anatomy. I'll show a little bit more specific here. The subclavian vein, you guys are familiar with this kind of part? Okay, so lateral to the IJ, or the innominate junction, where you go up to the jugular, there's going to be, you've got your subclavian vein coming out from under the clavicle. It has two main branches, the axillary and cephalic veins. Cephalic is more superficial, and axillary is less so. Axillary is kind of your armpit. Physicians will do either a cut down, which means they will directly dissect, blunt dissect to expose those veins, and then introduce the lead in that way with a puncture. Some people will do a micropuncture kit, which is a small needle, or a regular size needle, which we provide in our access kits. Access kit's going to have a big syringe. I don't know if they have a picture of this. Let's see. Here we go. So this is an access kit, right here. They're going to have, there's an introducing sheath, which has a dilator. There's a guide wire. You don't put anything in a vein or a vessel without a guide wire first. I think why that is. fence dissection of the vein. So guide wires naturally follow the inside of the vein. They have a blunted J tip, so they're not going to be able to poke outside. So once they're in the vein, they're going to stay inside. And because they're nice and floppy, their movement is very informative about what's happening with that vein, right? Is there resistance? It's going to bend. You put something hard through, you won't know. You'll go right through the wall. So guide wires are really helpful in ensuring that we get quick, safe access. And you'll see it all over cardiology, all over vascular work. If you're going into a blood vessel, they use guide wires. So these are actually 0.35, which is the fraction of an inch. Inch and millimeter, I'll tell you that. And then they'll use a syringe mounted with a needle. And they'll pull either with saline, and they'll pull vacuum, they'll pull back, they'll aspirate, or they'll just use vacuum in there, they'll just take all the air out and pull back on it. When they puncture the vessel, purple blood, it's really red, but just less pulsatile than arterial blood. And they know they're in, they introduce the guide wire through the needle comes out, they're in. And then you introduce the sheath and put the lead in. So, looks kind of like, it's called the Seldinger technique. Kind of looks like that. So wire goes in and then catheter goes over the top. All right. So, once we're in, I just want my picture. That's in order to get it based on anatomy of that patient. So, and we verify it on floor. So this lead looks like it's in the RV apex. And we'll talk tomorrow kind of how we know where we're at based on kind of position relative to the spine and just kind of how it moves. A lot of this is done by understanding of typical anatomy, experience from seeing how these things handle, and then just kind of intuiting, okay, where am I now? And you know, we're limiting the parameters a little bit by knowing that we're not enabling the lead to push with particular force. We're watching the EKG to see when you go in the V, do you get ectopy? When you go in the A, do you get atrial ectopy? And all of that helps inform where we're at. And look in multiple views to make sure you're not like going into the coronary sinus. Okay, so like I said before, we're looking for good sensing. So how big are the intrinsic R waves? Right? How big are the ventricular complexes that you're sensing inside? And the same with the A. And then how much pacing output do we want? So in general, sensing in the A, you want more than 2. Sensing in the V, you want more than 5. That's millivolts. This might be something he would ask. I mean, I don't know the answers. This is like a pretty...
A is more than 2 millivolts.
A more than 2 millivolts, V more than 5 millivolts. For sensing, you want below 1 in both. Now, can you deal with worse numbers than that? Absolutely. Some people just don't have an ideal.
Sorry, for pacing below 1?
Pacing below 1 volt. You want thresholds, basically, the required output to be below 1. That's good numbers all around.
So then, sorry, maybe I missed this. misunderstanding.
Mhm.
So with pacing, you won't below 1, the 5, the 2, and the...
That's for sensing. So sensing's in millivolts, pacing's in volts. Impedances on bipolar leads are going to be between 200 and 1,000 ohms, generally. So we test with the PSA. We're going to do some things like we're going to make sure that there's no epicardial stimulation of adjacent nerves. So you have your phrenic nerves running alongside the heart that innervate the diaphragm. If you happen to pace too high, or if, God forbid, you have a perforation of the heart where the lead is sticking out into the pericardial space, that energy may capture the nerve. And so we do high output pacing. We pace at 10 volts, which we would never pace through a pacemaker. And we just make sure that we're not capturing anything that way. So we say, okay, 10 volts. Physician will feel for diaphragmatic stimulation on both sides, which is just, vigorous hiccuping. And then, yeah, you're slamming the diaphragm instead of a smooth, like this. It's like they move quickly. So. There you go. So there's our numbers. Yeah, greater than 2, sensing, greater than 5, yeah, and less than 1. All right. As time goes on, there's an interaction of steroid, scarring, acute inflammation in response to being stabbed that change the properties of the interface between the lead and heart. So you can get fibrosis and scarring, which makes things worse, or you can get the effect of steroid, which makes things better. So all of this is, it changes over time, but ideally it stays within it.
Sorry, you said the effect of steroid?
Yeah, there's steroid built into the lead tips, so it's actually inside the kind of the central plug of the lead. It prevents acute inflammation of the local tissue, and so that you don't get capture thresholds that are way out of whack. All right, so you screw in, you connect, and then they close the pocket. While all of this is done, we're using the programmer to communicate with the pacemaker, because there's a wireless connection now on all of our devices that we're putting in. And we have a pacemaker that's not, but by and large, all ICDs out there and a lot of pacemakers have wireless communication, which means we don't even have to put a wand over the sterile field. You can do all this just wirelessly. And we continue to watch what the rhythm looks like beat by beat. We continue to test the lead to make sure that there haven't been any acute changes in the stimulation threshold, or we've got bad sensing. So things that can happen during the case that maybe the rep watching that would catch are the atrial lead can fall out. It drops out of the atrium. The ventricular lead could pull back. Generally, it's the end of the line. It doesn't fall out of the ventricle, but because it's being pushed down and gravity kind of wants it to go that way. Whereas the atrium, you're more anterior when the patient's laying supine. So if it falls, gravity's actually pulling it down. And flow of blood going past it is pulling it away. Whereas the ventricle is just kind of inclined to sit there. We could identify dislodgement intraoperatively and then intervene quickly, not have to wait till the patient went home and, oh gosh, we got to bring him back in. You just fix it right there.
Does the likelihood of dislodgement decrease, within the first how many hours, or is it?
Yeah, if it hasn't dislodged within the first day, you're mostly out of the woods. Yeah, the likelihood of dislodgement is highest in the right after positioning, right? Because if it's held that long, you're
The one with when here was showing us some of the sample pacemakers, and the one with the little things that stick out, but it's not a screw.
a micro. Yeah, so those are
It just seems so flimsy. It kind of reminds me of something.
they're leadlet. Well, yeah, that is the competitive mode. Yeah. Ours is far sturdier. The, or I hear, the micro devices or leadless pacemaker devices are designed to, they go in through a different puncture site because you have to have a more straight line. So they go in through jugular, or I think you can do them via femoral sticks. So they go through a much larger vein. They position using a catheter and then screw into or in the case of Medtronic one, it's just a passive fixation. So those little hooks just kind of hang on, and it works that way. But there are limitations, as you can imagine. You can't put one in the atrium because it won't hang there very well, at least right now. In order to communicate with each other, it's more complex. So, and if you've got to replace it, well, the battery's inside the heart. So now either we have to remove it or put some other type of device in it. So we'll see. By the time we all get them, maybe they'll be like that. All right. So general steps of a pacemaker implant from beginning to end. What do we got? We call it access. So we get access.
You stick your guide wire, or the guide.
So we're going to do Seldinger technique,
So you
where you're going to introduce a guide wire with a needle.
aspirate.
I didn't say, but often that part of the procedure is guided using a venogram. So they will choose the arm on the side that you are accessing on, because you got to get the dye to flow through those veins. You go downstream, or rather upstream, introduce dye under fluoroscopy, and you'll see it light up the potential target veins. And it'll help us identify, okay, is there a valve here? Is there an occlusion or stenosis? Is there scarring? Does the patient have something in there, like a fistula? If patients, like I had 2 patients on dialysis today from the clinic who had to have their devices put on the other side because they had a dialysis port, right, and it gets in the way. Cool. Okay, so needle in. What vein are we typically going to stick in?
Well, I think it's a big name, but there's entry in the cephalic or
Axillary?
Axillary. Yep. The one you're going to cut down would be the superficial one, which is the cephalic. You can stick any of those 3. It's just harder to stick the small ones.
It's just surgery preference.
Yep. Depending on I work with a guy in Chicago who would put it he would put it in the axillary, do axillary sticks, because he thought, so the closer you are to the clavicle, you're actually going right under the bone. You risk trauma to the lead because you're on bone, right? So flexing is against a hard point, and that can create damage to the lead, right? You get much less durability if you're on something that isn't flesh. So not wanting to have the patient have to get new leads someday, this physician would choose, axillary sticks all the time, and the patient's devices were like in their armpit. But, it's not like the end of the world. Okay, so that's how they go in. Let's see if we got a video. Patients being implanted in Jamaica, so that's the music. So it is most common to do access from the left. And if you can imagine positioning that lead, one smooth curve, right? Big C, basically. From stick to the SVC.
When the part is not tired and the pacemaker it's a game, it's a physiological game.
It's more complicated because you have to make a double bend. Now, you can do it, right? It's just most guys prefer this side. Also, if you think about, okay, patient's laying like this, physician standing here, what handed are most people?
Right?
Yep. So if you're right-handed, it's very natural, right? Like this.
Yeah.
If you're left-handed, you're doing it backwards. You're doing the work like this instead of like this. So,
Thank you.
yeah. All right, so this is, we'll see if this is enough. I don't know why you're not wearing a mask and you have an open table with some makeup and there's no patient. Are they going to actually show how this works?
The part normally, the reason for
So
it
I'm
is
just gonna
this
do it
lady.
here. Okay, so preparation for the procedure is done with iodine prep. Clearly they're implanting a Medtronic here, which is why we know that medicine is not as good in Jamaica. All right, so the prep is going to be done with, they'll use chlora prep or iodine preps they'll scrub the surface completely hair-free, right? We got a patient, if they're really hairy, they shave and buzz that whole region. Most physicians will prep both sides in case you get in here and you can't get access on one side. We're not having to redo the procedure. You don't have to re-prep the patient, we just transition to the other side. If we think that there's potential for complications where this patient has multiple stings in already, they may prep the whole chest and be ready to do, if they have to go to heart surgery, right? That way they're ready to go. So here's actually, I think you already got the needle in. Look at this. That wasn't helpful.
So it looks like the both sides of the chest are very
In this case, it looks like one. Keep going. Okay, so at this point, he already has a needle in and a wire in, and he's going in with the introducer. So the introducer is going to be introduced with all of the wire through. You never go in where you can't see the end of that wire because it could push in and then you don't have it anymore, right? So the wire is going to go all the way through the introducer, then the introducer starts going into the stick, and it's going to dilate up that hole in the vein with an inner dilator, and then the sheath, which is white, is what you see. That can then be peeled away with the lead in place. So we're creating a tube of access with a valve on it that prevents air from going in. Why do we now want to get air in the venous system? Yeah, we get air embolism. Air is compressible, fluid is not. So if the heart is trying to press and there's air in the system, it's not going to flow. You won't get return flow. And you can get, air embolism can actually block the capillary beds when it gets to some end tissue. So that's bad. So they're using a C-arm, kind of crappy fluoro. Well, the C-arm is less high quality. It was a portable C-arm. We have a C-arm as part of the fluoro system in every lab, right? But we call a C-arm a portable C-arm, which is like a surgical X-ray system. You can see it just has these little tube screens. That's of lower quality. And you can see it's not nearly as clear. So they're doing this in kind of an odd order. Patient has an IV, right, where they can flush if they need to. We tend to do larger veins than in the hand. They don't like to run large amounts of contrast through the hand. So he's bovine open the pocket here. Once the physician knows they can get access on the side that they're going to implant, then they'll do a pocket expansion to be able to create a place for the pacemaker. Let's see. I want better videos, Dr. Roger. Oh, here we go. So this is our access. This is totally not in order because he already has the pocket open, but now we're going back to access. Whatever. So in this case, he's wildly flailing around. Oh, this is actually just he's anesthetizing the area with local there. That's a very shallow stick. Here. All right, so this is just spreading around. This is lidocaine. Usually a good idea to do that before you cut open the pocket. Then they'll use a larger needle before this and get the stylet or the sheath in. I know this is in order. I'm sure another video will show that in a second.
So the pocket is prepped before the leads are inserted?
It depends on the physician. Some guys will go in. Yeah, I would say so. You got wires in, then you cut your pocket open, and then you go in with your leads.
I see.
And you'll actually suture down your leads inside that pocket to the muscle wall.
So then you're prepping it, and then you're shooting?
We say prepping, we mean cutting open the pocket.
Okay.
You're expanding the pocket. So you're going to create an incision that allows access to get just as big as the pacemaker is. And then you're going to have a pocket that extends below, usually blunt dissected just using the physician's fingers. Sometimes they might use it, well, you know, it's very atraumatic. So you go in with metal, you could hurt somebody. So, Medtronic rep not wearing a mask. What's that about?
This has gotta just be like B-roll from
Actually, can you pause that?